Establishing routine osteoarthritis examinations with your patients is an important first step in identifying and controlling osteoarthritis. Osteoarthritis is a common physical examination finding in older dogs. As a result, all dogs 5 years and older should be evaluated for osteoarthritis. Joints should be palpated for range of motion, crepitus, and pain. Joints of particular concern include the elbow, hip, and stifle. Also, be sure to examine the shoulder joint and joints of the carpus, hock, digits, and spine. By incorporating a routine examination for osteoarthritis into your patient's physical examinations, you will be able to detect the presence of osteoarthritis early and prevent significant pain, which in turn helps prevent aggressive treatment options. To identify osteoarthritis, look for an altered gait at different speeds of ambulation, joint swelling upon palpation demonstrated by joint effusion or hypertrophy of periarticular connective tissue or both, decreased range of motion as demonstrated by manipulation of the joint resulting in pain response or limited range of motion apparent in climbing or descending stairs, muscle atrophy of an affected limb or hypertrophy of an unaffected limb. For a differential diagnosis, consider analyzing the synovial fluid for color, clarity, viscosity, cell count, cell type, and presence of infectious agents, abnormalities in radiographic findings, personality and/or behavior changes. Engage your clients to discuss with you any changes seen in their pet. In addition, educate your clients about how to complete the Pain from Osteoarthritis Assessment Questionnaire. Responses from this questionnaire will help you learn about their dog's behavior and locomotion. Questions include 1. How would you rate your dog's mood level? 2. How would you rate your dog's willingness to participate in play? 3. What is your observation of your dog's level of audible complaining, such as whining or crying out? 4. Rate the following observations about your dog's locomotion: walking, trotting, running, jumping, lying down, getting up, difficulty moving after rest, difficulty moving after major activity. To use this questionnaire in your clinic, click on the Pain Assessment Questionnaire button to the left to print out a PDF version. A simple osteoarthritis examination can identify a patient in pain. The first step is to conduct a physical examination, following an owner's history of the patient. The osteoarthritis examination should include brief neurological assessment including conscious proprioception of each limb and palpation of the spine, examination of the carpus, elbow, and shoulder, examination of the forelimb musculature and long bones, examination of the hock, stifle, and hip, examination of the hind limb musculature and long bones. Use a pain scoring system to evaluate pain. Use of a goniometer from Novartis Animal Health, a tool that measures angles, can be helpful to routinely assess joint range of motion. To measure a joint range of motion, pivot the goniometer to measure the angle formed by the two bones comprising the joint. Move the two adjacent bones to extremes of extension and flexion. This measurement provides benchmarks for comparative changes. When making a measurement, it is suggested that 3 readings be made and the median measurement be selected for increased accuracy. As seen in this video, the goniometer is used to measure a healthy joint and a diseased joint to demonstrate the changes in range of motion. The goniometer can be used with the dog standing or recumbent. Another tool used to assess pain is the visual analog scale demonstrated in this video. Scoring parameters for the visual analog scale can include posture, gait, or movement, vocalization, restlessness, trembling, head hanging, appetite, stupor, aggression, growling, and withdrawal. The visual analog scale is a horizontal 10 centimeter line. The left limit represents no effect, for example pain, and the right limit represents the most severe effect, for example pain for a given circumstance. To use the visual analog scale, place a mark on the continuum from 0 to 10, representing the patient's current state. Rotate the 10 centimeter scale over the line. The mark is read to 1 or 2 decimal places. This is the pain quotient and is recorded in the patient's record. The anterior drawer movement gets its name from the analogy of pulling a drawer, the tibia in this analogy from a chest of drawers, the stabilized femur. The index finger of one hand is placed on the proximal patellar region, while the thumb is placed caudal to the lateral fibula. The index finger of the other hand is placed on the cranial aspect of the tibial crest, while the thumb is placed on the caudal aspect of the fibular head. With the femur stabilized, the tibia is pushed forward and then pulled backward. This is repeated several times and is performed gently but quickly to detect abnormal movement of the tibia in relation to the femur, which indicates compromise to the cranial cruciate ligament. Finger placement is important to elicit a drawer sign. Since the cranial cruciate ligament constrains anterior translation of the tibia, with complete tears, abnormal cranial drawer motion is noted in the extended and the flexed position. Abnormal cranial drawer motion in flexion but not extension suggests a partial CCL tear, craniomedial band of the CCL. A short 1 to 3 millimeter cranial drawer movement is normal in young dogs. Excessive internal rotation of the tibia can also be elicited in the cruciate deficient stifle. Cranial tibial thrust is a diagnostic tool used to diagnose a CCL rupture. Hold the hind limb at a normal standing angle with one hand on the metatarsal bones and the other on the stifle, with the index finger over the patella and tibial tuberosity. By flexing the hock joint, the tibia is forced into cranial drawer or a cranial direction. With an intact CCL, the drawer movement is prevented. Without a CCL, the proximal tibia moves in a cranial direction. With partial CCL rupture injuries, there may be an incomplete thrusting or no thrusting. Further, with a chronic CCL rupture, periarticular fibrosis may prevent tibial thrust and cranial drawer. Slightly flexing the stifle, the hock is dorsiflexed, which places the gastrocnemius muscle under tension. In the CCL deficient dog, the femur moves caudally with simultaneous cranial subluxation of the tibia. Movement of the tibial tuberosity associated with flexion of the hock is palpated with the index finger. The Ortolani sign is a noise or palpable thud produced when an unstable femoral head is subluxated, then replaced into the acetabulum. The unstable hip is subluxated proximally by grasping the stifle and pushing proximally. This forces the femoral head out and over the rim of the acetabulum. A noise or thud is thereafter produced as the stifle is abducted and the femoral head seats into the acetabulum. A simple thumb test can be used to confirm a coxofemoral luxation. In the normal articulating coxofemoral joint, external rotation of the femur will displace a thumb placed between the greater trochanter of the femur and the ischiatic tuberosity. Due to the strong influence of the gluteal muscles, most coxofemoral luxations result in dorsal displacement of the femoral head relative to the acetabulum. With craniodorsal displacement, the greater trochanter is dorsal to an imaginary line drawn from the crest of the ilium to the tuber ischii, and the distance between the tuber ischii and greater trochanter is greater than in the normal limb. In this case, the thumb is not displaced with external rotation of the femur.